We often celebrate mammography screening, and, rightly
Oh,
so.
absolutely.
It has been this monumental success story in public health, fundamentally shifting breast cancer detection.
And leading to a significant drop in mortality rates. We're catching things earlier.
Patients are absolutely benefiting.
That success is undeniable. But the sources we're diving into today, specifically the research in the European Journal of Radiology,
Yeah.
they force us to see a critical distinction.
Okay.
That remarkable mortality benefit is, well, it's primarily restricted to one major type of breast cancer,
The common type.
the common type, what we can call adenocarcinoma of the breast, or AAB.
So we found the standard blueprint for breast cancer, the one we really know how to screen for and treat.
Right.
But that implies there's a major subtype out there that's not getting the same benefit.
Worse than that is because we're misclassifying it completely.
Misclassifying.
And that's the core finding we need to talk about. Ductal adenocarcinoma of the breast, or DAB.
Okay.
Right now, this cancer is being misplaced within the group we call ductal carcinoma in situ, DCIS.
Which, by definition, means non-invasive. The name says it all, in situ. It's just sitting there.
Exactly. But the evidence now, it's overwhelming. It suggests that DIB is a distinct, highly aggressive, and invasive cancer.
Invasive.
And because of that misclassification, it's frequently underdiagnosed and, crucially, undertreated.
Okay, let's really unpack this, because that is not a small finding.
No.
That's a seismic shift. If an invasive, aggressive cancer is being treated like it's harmlessly locked away, the consequences for you, the patient, are just devastating.
They are.
So our mission today is to detail the six well-defined imaging biomarkers.
The visual signs.
The critical signs that radiologists can use to unmask DAB and force its recognition as the invasive disease it truly is.
Fickle.
So to understand why DAB is so unique, we have to start at its origin point.
Right.
If you think of the breast as a drainage system, sort of like a tree of ducts, most breast cancers, the AAB type you meant,
The common one.
they come from the terminal ductal lobular units, the TDLUs.
Little grape-like clusters at the very end of the line where milk production starts.
But DAB, it's different.
It completely ignores those little clusters. It's a fundamentally different disease. DAB originates specifically in the much larger ducts.
The high-traffic thoroughfares near the nickel?
The major lactiferous ducts, yes. And its signature pathology is a process called neoductgenesis.
Neoductgenesis. That sounds like something out of a sci-fi movie. What does that actually mean?
It means the cancer is generating brand new, abnormal duct-like structures. We call them neoducts.
Right inside the tissue.
Right inside. And they become grotesquely distended, sometimes by cancer cells, sometimes by fluid.
And the key anatomical giveaway?
These aggressive new structures, they lack any associated TDLUs. They are purely abnormal growth filling up those major ducts.
The analogy in the sources I thought was so helpful here for picturing this. They describe the normal major duct as being like a saguaro cactus with all those deep pleats.
That's a perfect image. The normal duct is collapsed and pleated, sort of like a folded-up accordion.
So it can expand when needed.
Exactly, like during lactation.
Yeah.
But with DAB, that same pleating allows the duct wall to distend massively as it gets relentlessly filled by this disorderly, rapid proliferation of neoducts.
And this kind of aggressive growth pattern, this neoductgenesis, is why it's been so hard to catch.
And classify correctly.
It sounds like by the time it even shows up on a mammogram, it's already widespread.
Precisely. This subtype can be shockingly extensive. We're talking several centimeters of affected tissue.
Wow.
And that's before the signs become obvious on a standard mammogram. The failure to recognize these distended neoducts as signs of an invasive malignancy.
And not an in situ condition.
That's what leads to the massive underestimation of the tumor burden and, tragically, to treatment failure. This isn't a sleepy tumor. It's a chaotic invasive vine growing along the ducts.
That really sets the stage for the urgency here.
It does.
If we can spot these visual clues, we stop calling it DCIS and we treat it for what it is. So let's talk about the images.
Right.
This is where it gets really interesting because DAB shows up in 6 distinct ways, and 4 of them are defined by specific malignant type calcifications.
That a radiologist can spot on a mammogram.
So we can group these 4 patterns.
We can. We can group them based on the underlying disease mechanism. Think of it as, what is the cancer doing inside the duct? Is it dissolving itself or is it flooding the duct?
Okay, 2 different paths. So tell us about the first group, Group A. This is where the cancer is characterized by intraluminal necrosis.
Necrosis meaning cell death or decay.
Right.
Exactly. In Group A, the cancer cells, and we're usually talking high grade, grade 2 or 3, they're growing so fast they outstrip their own blood supply and die.
So there's no fluid production here.
None. The first and most frequently observed sign, and honestly the most lateral mammographic sign of malignancy for this entire subtype, is fragmented casting-type calcifications.
What are we actually seeing on the screen when we look at that? What does that look like?
You're seeing amorphous, shapeless calcifications that are forming right in the central debris of those dead cancer cells.
So they follow the line of the duct.
They do. They look like branching, often broken up granular pieces. Pathologically, this is linked to a solid tumor growth pattern filling that major duct.
Okay, wait a minute. If this pattern is considered the most reliable mammographic sign of malignancy,
It is.
why on earth was the medical community labeling it in situ for so long? This feels like looking at a huge red flag and calling it a gentle wave.
That is the essential conflict these sources highlight. The failure here lies in the histopathology, not necessarily the imaging.
So the reading of the tissue itself.
Yes. And the researchers provide a devastating case example. A 63-year-old patient who had a massive 60-millimeter lesion.
60 millimeters.
Initially diagnosed as high-grade DCIS based on these exact fragmented casting calcifications.
And what happened to her?
She died of metastatic breast cancer just 3 years later.
That's sobering. 3 years after diagnosis, she dies from metastasis.
And here is the unequivocal evidence. The autopsy of her lung metastases showed duct-like structures containing the exact same casting-type calcifications seen in her primary breast lesion.
So the signature was identical?
The visual signature of the primary tumor was found in the distant metastatic site. This correlation proves, beyond a shadow of a doubt, that the initial lesion, the one called in situ,
Was invasive and lethal from the start.
from the very start.
That clarifies the stakes immediately.
Okay.
So the second type in this necrosis group is the dotted casting-type calcifications. How does the picture change here?
The visual's different. These appear as dotted branching patterns that look almost, well, snakeskin-like.
Snakeskin-like.
And they're also occupying a large part of the affected lobe. But the pathology is associated with a micropapillary tumor growth pattern.
So instead of a solid mass of cancer dying in the center,
Right.
you have these tiny finger-like projections, micropapillae growing into the duct.
Precisely. And in this scenario, it is the tips of those micropapillary growths that break off, they necrotize, and then they calcify.
And that creates that dotted, speckled look.
That's what creates the appearance along the duct. It's a different mechanism of cell death, but the end result is the same. Calcified debris lining the duct,
Yeah.
indicating aggressive high-grade disease.
Okay, so that's group A. 2 patterns where the tumor essentially dissolves itself, leaving behind this debris.
Exactly.
What happens when the tumor decides to flood the ducts instead? Let's move to group B, characterized by fluid production.
This is a totally different pathophysiological process. In Group B, the malignant cells, again, typically grade 2 or 3, they are actively producing a thick proteinaceous fluid.
But they don't die off.
They do not undergo central necrosis. This leads to intense pressure buildup.
So the duct is just swelling with its own toxic fluid.
Exactly. This increased fluid pressure distends the ducts even further. And if that fluid isn't successfully discharged,
Which it probably isn't if a tumor is blocking the way.
often it isn't. So it stagnates, it desiccates, and it leads to the formation of very specific structures, either amyloid bodies or large Samoma body-like calcifications.
And these calcifications are a bad sign.
They are critical. They typically signal a more advanced phase of the disease, often including lymph vessel invasion.
Okay, the first of these fluid production patterns is the skipping stone-like calcifications. Visually, the source material says these are highly deceptive.
They're the trickiest to spot on a mammogram alone
Why is that?
because they're spherical and oval. They resemble flat, scattered stones. They can easily be dismissed as benign calcifications.
Oh, how do you catch them?
The diagnostic key is their distribution. They are scattered exclusively throughout a single lobe of the breast following that ductal tree.
So the shape looks benign, but the pattern, the geography of it is highly suspicious.
Yes, and that sounds like a situation where you just can't rely on the mammogram alone.
You can't.
This lobar distribution is what makes them easily demonstrable on breast MRI.
Oh.
The MRI can show the full scope of the disease, validating that these scattered, seemingly harmless stones are actually advanced markers of DAB progression.
And the final calcification biomarker, string of pearl-like calcifications.
These are faint, tiny rows of calcifications. They're essentially those large body-like structures we mentioned, suspended in the protein-rich fluid.
So they look like delicate beads.
Fine rows of beads, exactly. The interesting caveat here is that this pattern can sometimes be associated with slightly lower grade malignancy grade 1 or 2.
And harder to see.
And the sources indicate they may be difficult to demonstrate fully even on an MRI. You really need high-resolution mammography for visualization.
That covers the 4 calcification-based subgroups. But you said there were 6 types.
Right.
So what happens in the 2 cases where calcification is completely absent? We must need different diagnostic tools for those.
That's right. When the duct is being flooded but the system is able to release the pressure, the calcification process just doesn't happen.
The fluid gets out.
Which brings us to the 5th biomarker, bloody and serous nipple discharge.
Ah.
This is still a manifestation of fluid-producing DAB, but the fluid is discharged through the nipple.
Yeah.
And that prevents the long-term stagnation needed to form calcified debris.
So because there are no calcifications, this is often occult. It's hidden on a standard mammogram.
Very often, yes. Especially if the cancer hasn't formed a dense mass yet.
So how do clinicians track the extent of the disease in that scenario?
It requires a truly multimodality approach. We rely on 2 primary tools. First, galactography.
Which is injecting contrast dye directly into the affected duct.
Yes. And the sources stress that galactography often has superior spatial resolution to an MRI for visualizing the tiny filling defects caused by the cancer's micropapillary growth.
So you inject the dye to outline the shape of the duct.
And the cancer shows up as little holes in that outline.
And the second tool?
Breast MRI. It will show extensive non-mass enhancement. This is crucial because it clearly demonstrates the low-bury nature and the extensive reach of the disease as it spreads toward the chest wall.
And our final biomarker, number 6. Architectural distortion without calcifications or nipple discharge.
Right.
This is often the type the patient might feel, right? As a non-specific, palpable thickening.
This is perhaps the most insidious sign. That asymmetric density or thickening you see on the mammogram is a direct result of that massive, disorderly proliferation of neoducts.
The ones we talked about at the start.
The very same. You have an unnaturally high concentration of these distended cancer structures, and they provoke what's called a desmoplastic reaction.
A desmoplastic reaction. So the tumor is hardening the tissue around it.
That's a great way to put it. The tumor causes the surrounding connective tissue to become fibrous and dense.
And that creates the distortion.
And the palpable firmness that can be mistaken for benign scarring or just dense breast tissue. It's the visual sign of invasion through mechanical force and fibrous response.
Okay, before we summarize the massive clinical implications of all this, we have to talk about one unique, definitive marker. The one that confirms the major duct origin of DAB, Paget's disease of the breast.
This is extremely significant. Paget's disease, that eczema-like skin change that appears on the nipple and areola, is unique.
How so?
It is only associated with cancers originating from the major ducts, meaning DAB. It acts as an undisputed geographical marker for the source of the cancer.
So if a patient presents with that skin change, it's not just a skin issue.
It's confirmation.
It's confirmation that the underlying extensive cancer is DAB.
It's a neon sign indicating high-grade cancer. The sources confirm every single case of Paget's disease has an underlying DAB that has extended right up to the nipple epidermis.
So if you find those Paget cells in the skin,
the diagnostic recommendation is clear. Immediately utilize breast MRI. It is the most sensitive method to show the true presence and, frankly, the astonishing extent of the underlying high-grade DAB.
And this is often long before calcifications have even had a chance to appear on the mammogram.
Exactly.
So what does this all mean for the patient, for you listening, and for the clinical community? We've reviewed overwhelming evidence, from the casting patterns found in metastatic sites to the definitive presence of Paget's, that ductal adenocarcinoma of the breast is an invasive disease.
With a clear, poor outcome if it's mismanaged.
It just cannot be continually categorized as an in situ condition.
The current paradigm must shift. This evidence demands that the diagnostic criteria for what we're calling DCIS be urgently reevaluated and reformed.
And beyond that.
Furthermore, the source material points out that proper management requires specialized techniques that are not always routine in clinical practice today.
Like what?
Specifically, the necessity of using the large format histopathology technique.
And why is that technique so crucial for treating DRA?
Because the sheer, extensive, and disorderly nature of this neogenesis means that the full spread of the malignancy is frequently underestimated
Or completely miss.
or completely missed when you're using the smaller glass slide techniques that are common today. You might only catch a tiny cross-section of a disease that's centimeters long.
So the large format technique ensures the entire ductal unit is assessed.
It gives the oncologist a true measure of the tumor burden before treatment even begins.
Precision medicine just demands that we acknowledge this accumulated hard-won evidence.
We have to.
We need to move past outdated classifications that are failing patients. So let's leave you with this final provocative thought to mull over.
Okay.
If these 6 biomarkers are subtle, extensive, and often missed with standard viewing techniques, what specific technological steps could accelerate the earlier detection of DAB for future patients? The research suggests a highly actionable path: systematic use of image enlargement and appropriate window leveling during routine screening, combined with the swift implementation of effective artificial intelligence programs.
AI programs specifically designed and trained to spot these extensive, subtle, but highly malignant ductal signs.